lie on your back, and this time I'm going to slide this over here a little bit more. And figure out how people can see. Not really know what I'm doing. Here, with this, get a piece of this. Now again, this is a higher table. With the tables in the room, you know, a regular chair or even the rolling stool is beneficial. But make sure we understand how to do these things properly. So this is for an internally rotated humerus and an externally rotated humerus. And so for an internally rotated humerus, we're going to externally rotate to adjust it. Get all this stuff out of the way. I'm going to put the mid forearm to my mid thigh, and notice I'm positioning him so his hand is not between my legs. Points off for putting your patient's hand in your crotch. Okay, so be careful with that. And then we're going to take a broad contact with your arm, notice that, using my entire index finger, thumb, and thumb web of both hands with an internal to external rotation tissue pull. And again, I'm right next to the acromion, so I'm very high on the humeral head. So I start like this, take the tissue pull to externally rotate. So now my proximal forearm is on his distal forearm, and pressure causes external rotation. My hands and thumb web of both hands are also externally rotating and take both to the end of range of motion. I stress and thrust, and of course this patient has a negative apprehension test before performing this test. Questions? Notice we're a little bit less than 90 degrees abduction, so we don't cause any impingement. Notice that I have mid forearm to mid thigh, not the elbow. There's too much leverage here. I want mid forearm to mid thigh. For an externally rotated humerus, it's completely analogous. Now I'm going to internally rotate. I place the mid forearm to the mid thigh. Again, the arm is a little bit less than 90 degrees abduction, so I'm not going to be pinching anything like critical zones. I'm going to take an external to internal rotation tissue pull, and I'm right next to the acromion. I'm not in the humeral shaft. I'm right next to the acromion. And now my proximal forearm pushes on his distal forearm. My hands are causing internal rotation. I do both at the same time, end of range of motion, feel for springiness, and thrust it, fixate it. Questions? Okay, I'm sure I'll look there next. The AI humerus. And then we do the medial humerus. Good. For the AI humerus, again, we can have him supine or seated. And so the elbow can be midline, and so now again he's internally rotated. That's one type of cartilaginous contact. Could have the hand behind the neck. Now he's externally rotated. That's a different type of cartilaginous contact. Is this comfortable for you? Mm-hmm. Good. And so now in this position, we're going to stress A to P and I to S and medial lateral. If you're going I to S, there's an important contraindication, which is contraindication to thrusting from inferior to superior. Say louder. Exactly. So upon contraindication. So what I'm going to do, I'm going to grasp the scapula in either of the positions we described, pull it inferiorly, stress and thrust from A to P, medial, lateral, and superior to inferior. So I'm stressing the scapula down. I'm taking the humerus and stressing it from A to P, medial, lateral, superior to inferior. And of course, all your tests for impingement syndrome are negative. So can we sit up with this next? And again, scoot back on the table so you're back far. This is kind of a high table for this, but I think we can do it okay. And put the hand behind the neck in some situations, on the other side in other situations. And notice the difference here. This is for a seated anterior humerus at 90 degrees flexion. It's not risky for impingement syndrome because there's no I to S stress. Bring the arm down. That's good. This is for a seated AI humerus. And in this position, I'm going to be stressing and thrusting also from inferior to superior. And of course, there is a risk to that. And with this one, we actually lean back against me. Give me all your weight. So I kind of have him leaning back against me as I'm going to stress and thrust in this position. We good? Thank you very much. Stay right here. We can do a couple more. Paying close attention. Okay, elbow. We have posterior radial head. Let me actually stand up for this. So finding the posterior radial head, of course, it's the distal bump, and I can feel it when I supinate and pronate. And I'm going to take a P to A tissue pull, a nice broad contact. I'm going to stabilize this part's important, very specific, on the ulna. Broad contact squeezing those things together, feeling for that springiness. And I supinate and stress and thrust P to A, a little bit louder medial if it's fixated. It's in supinated position. I pronate with stress and thrust. It's P to A and louder medial. And so one of the mistakes people think, so if I have to go this, if I'm going to pronate, and that's bad mechanics for me, right? The shoulder, this is shoulder movement. I move his shoulder for my purposes of giving me good biomechanics to thrust from P to A and lateral medial. Same thing with supination. I don't need to do this. I'm supinating the forearm, and now I'm positioning the shoulder for my purposes so I can give him a good position. What else can I do? Same contact for a jam joint. Thumb covers another thumb. He stands up nice and straight, and I simply thrust from S to I was one of them. And then also we described briefly the posterior ulna, very delicate adjustment now. Take the inner range of motion, very short thrusts. You can injure people like this if you don't do too much. But sometimes you need that little extra range of motion at the end of extension for a posterior ulna. Questions? Thank you very much. You put your shirt on and grab me. One other person. Did you come out here? Yeah. And wrists. So you guys might want to focus in a little bit on this because it's small. Instead of just see if I can figure out how to do this so people can see what we're looking at. I think what we're going to do is maybe sit facing this way. See if that's going to work for you guys. Is that going to work?
Battery's
Battery's dead?
Yeah.
Okay. The movie True Lies. Ever seen that movie with Schwarzenegger? It's a good movie if you've ever seen it. And there's one point where the terrorist is, videoing him. Power goes out. You know that scene, don't you? Okay, so AP glide. And we join this one. AP glide for the carpal bones. This is more generalized manipulation is done for the wrists. And so what I'm going to do, I'm going to grasp the ulnar and radial styluses. And very next to that, the proximal row of the carpal bones. Notice I'm keeping my elbow locked straight. You can relax your elbow, but my elbow is locked straight. And I'm simply doing AP glide and feeling for springiness. And if there's a loss of springiness, we can simply thrust to create the movement. Then we move and stabilize the proximal row and contact the distal row and do the same thing. Thrust if it's fixated. Then we contact the distal row, and then we contact the base of the metacarpal heads and do the same thing. Stress and thrust, stress and thrust. Bear with me on that? So AP glides. These are general manipulation techniques. Of course, we check to make sure they don't have instability in the wrist for that purpose. Okay, I'm going to take this one now. And so then we have a posterior lunate. I'm just changing hands so I think you can see better in these processes. So I've got to find the lunate. So finding the lunate and capitate, this is important things to be able to do. And the lunate in particular, so I hope I've banged it into your heads enough that you're going to check the scaphoids. Whenever there's a fall and after stage, you check the scaphoids. But someone in this room, somewhere in your career, you're going to find an acute fracture of the lunate. And the person's going to get put in a cast, and you will prevent Kienbach's disease. And all the orthopedists in your neighborhood are going to think you're a god, because that never happens. But it happens to you because you know where the lunate bone is, bottom line. And it's really tender when you palpate it. You better make a closer check. You won't see it on x-ray. You need a bone scan or a CT scan to see the fracture, and then you put it in a cast. And now you've prevented the degeneration, the vascular degeneration. So you take the third metacarpal, palpate carefully. I find the capitate. From the capitate, come a little bit ulnarward. Yeah, think about that. Ulnarward, and I put my thumb right on top of the lunate, and I cover it with another thumb. So covered thumb, doesn't matter which one's on top. I'm going to extend the wrist only slightly, and I'm doing this motion with my index finger. So notice what's happening, okay? I am, the middle phalanx of my index finger of both hands is distracting. And so I'm doing this kind of motion on both sides, which allows for the movement of the lunate. I can feel it if it's fixated. And so again, finding the lunate, I'm going to flex a little bit. Once I contact, you bring them into a little bit of extension. I do not hyperextend, that locks it in place. Just a little bit of extension, and then the thrust is simply P to A, just like that. Now, that's it. Posterior lunate. Then we have the anterior capitate. So I find the capitate, that's the divot. So I follow the third metacarpal, and there's a fossa, or a divot there. That's where the capitate is. And then I got to palpate anteriorly and try to find out where's the anterior pole. It's not easy to do. There's a bunch of tendons in the way. So it takes a little practice to get your finger right on that spot where I'm pushing ventrally from ventral to dorsal, and I can feel the movement at my thumb. So I know I'm on the right location, and then I cover that with another index finger and stabilize adjacent carpal bones. This one involves distraction. So you're going to lean back a little bit. He leans back, and I stress and thrust from A to P with a little bit of flexion. I do not hyperflex. It's just a little bit of flexion while he's helping with the distraction. Got it? So you stand up. Another jammed joint that can occur at the metacarpal. So this is the first carpal metacarpal joint, saddle joint, very important joint here. And of course we know it's not fractured, so you rule out fractures. Now I'm taking a broad contact on the first metacarpal. Notice I'm not posterior, I'm not lateral, but it's kind of in an oblique position. That orientation is what allows us to oppose the thumb. It's part of what makes us human, to be able to have opposition. Now I'm going to cover that with my pisiform so that my forearm is parallel to his forearm. I'm grasping his thumb in this position. He stands up nice and tall, and I simply thrust S down. That's all they do is to just thrust.